in the session, so we are kind of slightly making a longer talk, so we will be finishing on time despite the clock. But anyway, now starting, I'm going to talk today about the MSK infection in children and what is really new in imaging and what we are doing. So just to remind you that osteomyelitis, as you know, can occur at any age, but it's very, very common in children between 2 and 12 years old, more common in males for some reasons, 3 to 1. And we have the increased risk in elderly and the patients with systemic disease, but in children it's difficult to diagnose because there are non-specific symptoms, but also because it's difficult to communicate with the little patients. So common in children less than 3 years of age, and usually in these children there are in the metaphysis of the long bones. There could be vertebral osteomyelitis in about 25% of the cases, or it can happen in the pelvis. As an etiology, there are 3 ways to go. It could be hematogenous spread, which is the most common, soft tissue ulceration and contiguous spread, or due to trauma. And hematogenous spread is really most common in children, but it's very, very specific to the different age of the patient because we remember the differences in the vascular anatomy. And you can see it here in the infants up to 12 months. We have a patent vessels going through the growth plate. This will stop without the penetration, vascular penetration between the toddler and children. And then again, we will have the vessel extending through the now closed growth plate in adults. So the differences in the location and the spread of the infection in neonates will be metaphysis-epiphysis joint, in children metaphysis, and in adults again metaphysis and epiphysis. And this is important how we image and which part of the bone we are concentrating. Very often in osteomyelitis, there are not only osseous abnormalities that I listed here on this slide, but also we have a soft tissue abnormalities. And very often the soft tissue abnormalities are first visualized on our imaging. And we all know that early diagnosis in infection of the MSK system is very, very crucial because the process is very, very fast and it leads to the joint and the bone destruction. So we all know that the X-ray is the most commonly used in pediatric or in any other form of adult imaging. But we need to remember that osteomyelitis or the changes in the bones might extend at least 1 centimeter and compromise 30 to 50% of bone mineralization to be visible on the X-ray. So we all know that early changes until 5 to 7 days in children and 10 to 14 days in adults may not be visible. But then it's too late because the destructive process is already happening. So what we are seeing as an early signs, I talked about this, soft tissue swelling and the loss of the normal fat planes, and you can see it here in this patient, mainly on the lateral image, indistinct or irregular cortex and regional osteopenia. And when we do the magnified images, you can see much more clearly the changes in the soft tissue and the bones. But when it's visible on the X-ray in this form, look at the MRI performed in this patient, and you have seen very, very extensive changes in both diffuse changes within the bones, within the joints, and in the adjacent soft tissue. So the process at this moment, at this point, is very advanced. Another example, very subtle lucency adjacent to the growth plate in the calcaneum. And if you do the MRI, again, much, much advanced infectious process. So the X-ray, it's not very specific in these conditions. Subacute changes, so then we are describing the changes within the bones, starting from the regional osteopenia, going through all of the steps to the new bone formation and the peripheral sclerosis. So and these changes are much more easier to spot on the X-ray. But X-ray is a really nicely to perform as a comparison or as a follow-up of healing osteomyelitis. That you can see here the subacute changes, the X-ray in the middle taken a month later, and then we have an X-ray taking 6 months later and 2 months later with a complete reconstruction and rebuilding of the bone structure. Again, very, very subtle changes on the lateral X-ray, and you can see it that on the MRI it's much, much more extensive. So one of the lesions or one of the chronic changes that we very often see on the images performed for the pain or for the trauma will be a Brody's abscess, and we all know that it looks like a lytic, usually oval lesion in the surrounding sclerosis, and a very typical appearance that we all know, and we don't have any difficulties to describe this picture. And again, we can do a MRI to help our surgeon in visualization in the lesion and planning of the abnormality. Very often we don't give contrast in this patient because the Brody's abscess, as you can see here, it's very, very well visualized. But it's some other abnormality on the MRI here that you can see a fluid within the joint and the fluid within the subcutaneous soft tissue. We need to know, is it just the effusion or is it the a collection? We gave the contrast. And you can see here very extensive changes apart from Brody's abscess in the joint, in the subcutaneous tissue, and again collection on the site. So that's the X-ray. Not very specific, late changes, too late for diagnosis of our patient. Ultrasound. Why not you do use the ultrasound in MSK infection? We all know that is the limitation is visualizing changes within the bones. But we all know that ultrasound is very easily available, and we can look at the soft tissue and the joints adjacent to the infected bone. So we can see the cellulitis, soft tissue abscesses or collections. And have a look here on the few examples, very diffuse changes in the edema in the subcutaneous soft tissue consistent with cellulitis. You can see also visualize the soft tissue abscess, as you can see here, simple abscess or the more complex abscess with a lot of pus and multiple segmentation, multiple collections and septations. Then we can look also at the joint effusion. And ultrasound here is very, very useful. It's much easier to perform, quicker and cheaper than the MRI. And you can see here that the joint effusion is visible here on the scan, but the fluid within the joint is pure black. So you think that it will be clear fluid without the infection. Here, however, it's completely different. You have had a heterogeneity of the fluid and increased echogenicity suggestive of pus and underlying infection and the collection. What else we can do it? Apart from assessment of the soft tissue, we can see where the collection is extending. Is it just within the soft tissue, as you can see it here on these images, or do we have a paraperiosteal or subperiosteal collection? Important for us and the surgeons because they treat it in a different way. And you can see here this kind of complex collection adjacent to the bone, but the underlying bone is completely intact and the periosteum is adjacent to the bone without the lifting. And again, much more advanced collection, you can see here these changes within the bone. Here, the periosteum is very, very thin and well defined, when here you have changes in the underlying bone, so you're querying that the collection and the changes, the infection process goes into the bone, and it's a osteomyelitis there. But this shape and the size of the collection is completely different. You can visualize here the elevated periosteum and the collection visible between the periosteum and the bone, and the different example here. So again, ultrasound here, it's a very, very useful examination. And you can see the other changes when it's the periosteal collection here. But again, underlying bone is intact. When you have the periosteal reaction here, but the changes in the underlying bone consistent with osteomyelitis, plus you have changes here within the bone in the joint space, so you worry about the extension of the collection into the joint and into the bone. And again, couple of the assessment and the examples that with the ultrasound, you can't see the deeper part of the bone, but you definitely can see the superficial part. Here, very well visualized, and again, changes in the underlying bony structure adjacent to the massive collection, and with chronic osteomyelitis, developing erosions and the changes within the bone. So ultrasound, it's very often forgotten tool in the images of the osteomyelitis, but how useful can it be in our small children? And a few examples with the big collection adjacent to the bones, you can see definitely on the ultrasound that the bone is very abnormal. When you do the X-ray, it will confirm the changes, and the MRI will delineate the infection. But the main diagnosis is main on the ultrasound. And another example of the erosions and the changes within the distal femur and the changes and the infection extending into the joint. We also have the nuclear medicine that Tim was talking before, that is very useful in looking at the infection. We can use the bone scintigraphy with the TC99 or with the label white blood cells. We can use the gallium scintigraphy, or we can use the FDG PET-CT or MRI, which is much more useful in the current patients. And however, we are kind of looking away in imaging of the MSK system into the MRI because it's just much easier examination to perform, and also we don't have the ionizing radiation. So MRI is really examination of choice with looking at the bone structure, because we have a very good visualization of the anatomy, both soft tissue joints and the bones. And also MRI is the most sensitive imaging technique looking at the early changes within the bone marrow, especially bone marrow edema. We can look at the extension of the disease and also as a differential diagnosis. So when we do the MRI in the infective condition of the MSK system, always one sequence to represent anatomy, T1, pathology with the STAIR, and review for contrasts for this patient if the surgical intervention is planned. And if the surgery is planned, we usually would like to have 3 different planes to visualize the abnormality for our surgeons. And because these children that are often in pain, they don't stay still for MRI, we would like to use as fast sequences as possible. So always the most important sequence first, because the patient may decide not to cooperate any longer and we won't obtain the examination. Short sequences, size of the calls always relevant to patient's age because you will have a much better imaging. Assessment of the pathology, large field of view may be required to look how far the infection is extending, and visualization of the anatomy, detailed anatomy with the smaller field of view if the patient is going for the surgery. And you can see here how quickly the signs of infection, the early signs, mainly the edema, can be visible. And you can see the example on the T1 image, very, very subtle edema here within the metaphysis, and much nicer visualized on the edema more advanced on the STAIR image or the edema on the T1 image. And again, we can look at if edema is extending or the changes extending into the periosteum. I can see here the small amount of fluid adjacent and the changes within not only metaphysis, but the changes extending here into the epiphysis and the secondary ossification center. So again, very, very important, because if we don't react very quickly, the ossification center will be damaged and the child growth will be definitely affected. And again, another example with a edema within the calcaneum, and then on the images, more detailed images, you can see this small abscesses formation within the bones. Formation of collection is really important to visualize because if you have general osteomyelitis, patient will be put on the IV antibiotics. If you have a formation of the collection, the patient will need to have a surgical treatment. And the collections could be really, really small as a subperiosteal or periperiosteal like here, or it can be within the growth plates, and this definitely will need a very, very fast treatment in this patient. And you can see here again the different examples of the subperiosteal collection visualized on the MRI. Also, MRI is very useful with the further characterization because you can see here on the X-ray, soft tissue swelling, the skin, overlying skin was very hot, it's very edematous, the patient had a lot of pain. So we suspected that it was a collection, but as you see here, we can visualize the collection very, very well with the MRI, and by giving contrast, we can see the different parts of the collection, but also MRI will show us changes within the bones consistent with osteomyelitis. Is it important? Yes, because the collection will be treated with a surgery. But if you have an osteomyelitis, patient will be between 4 and 6 weeks on the antibiotics. Again, extension of the disease is really, really important. So you can see here the changes within the distal tibia, mainly on the lateral image, extending here very, very close to the growth plate. We can see also the changes here within the epiphysis. So by doing MRI, we can visualize the changes that we expected on the X-ray. But you can see here this collection not only extending through the growth plate, but also extending into the joint space. So this patient developed already septic arthritis. And as you know, the pus within the joint will make a destruction of the joint very, very quickly. And extension of the disease, it's incredibly important to look, and you can see here the soft tissue swelling here around the shoulder with the few loosened areas suggestive of the gas formation. And if we do the MRI and give contrast, you can see this massive collection within the shoulder. This was one of our neonates, and everyone was worried that this patient will have a sarcoma, but it was an extensive abscess. Differential diagnosis is important. You can see here very massive, very abnormal. Can I have another 3 minutes? Very abnormal looking femur with a soft tissue swelling around. And when you do the MRI, you can see here that this is not a tumor. This is consistent with infection, and the arrows will show you multiple small pockets of air consistent with a X-ray and axial images. So differential diagnosis is very important, showing you here the massive joint effusion, but also abscess within the patella. And if you look on the sagittal images, you can see here the foreign body extending into the patella, which wasn't visible on the clinical examination. So osteomyelitis with the imaging, what's new? The new is that we need to know now that we need to act very, very early, because our pathology study shows that the destruction of the bone and the joints is progressing very, very quickly in children. So we have a radiography, ultrasound and MRI. Radiography, yes, we do it to visualize the bones, but it could be we may not be able to visualize at the early stages. So ultrasound and MRI are preferred technique. And with this, I will say thank you very much for your attention. Because